Hello, everybody. Just a quick heads up. This session is pre-recorded, so we're just going to play the video, and after we will skip to the question and answer session. Enjoy.
Hello, everyone, and welcome to this very short presentation about the Swedish Medication List project. A few quick words about myself. My name is Emmeli Gross, and I work as a solution architect at the Swedish eHealth agency, and currently in this project that I will be talking about. Also, some background about the Swedish eHealth agency. So the agency was formed in 2014, so it's a relatively young agency. And our missions, we work with coordinating the government's investments in eHealth. We also host a Swedish National Database for Swedish e-prescriptions. We provide the Swedish medical statistics. And now currently we are working with developing the Swedish medication list. So what is the Swedish National Medication List? What this first version will deliver is a digital service to all healthcare staff, pharmacists, and patients, where they can all get access to the same information about the patient's prescribed and dispensed medications, with the aim to improve patient safety. And how will this be done in practice? So the Swedish eHealth agency will build a registry for the National Medication List, and healthcare systems and pharmacy systems will connect through APIs. What about the prerequisites? So in May next year, there will be a new law about the National Medication List that will come into force. This means that access to the service will be allowed from May next year. But as you understand, it will take a while for the healthcare and pharmacy systems to integrate to these new APIs and create new functions and new user interfaces. So therefore, the law permits a 2-year period until participation becomes mandatory, and that will then be in May 2023. And as I mentioned earlier, the Swedish eHealth agency hosts the National Registry for e-prescriptions. And it's the same systems that are connected to that registry that now will have to integrate to this new national medication list instead. So today there are about 50 different systems connected to our current APIs. So now moving over to talk about the actual techniques that we are using. Our current APIs are based on the service-oriented architecture using WebService and the WebService protocol and SOAP. But in the National Medication List project, we decided to go for RESTful FHIR API. And as I mentioned earlier, the external systems are allowed to connect to the National Medication List from May next year. So many of them have already started their implementations. So for many systems, our adoption of FHIR also means that they will have to shift to a new technology and a new paradigm. But at the same time, a lot of our old services will remain, which means that many external systems will have to use a mix of RESTful FHIR services and traditional SOAP WebService APIs to connect. There has been a lot of challenges along the way when adopting FHIR, a completely new standard for us. So I have picked out a few that I would like to mention. So before we even decided to go with FHIR, we did our first analysis of the FHIR resources and attributes to try to understand how well they fit our purposes and needs. But this type of questions is something that we have been continuously working with throughout the whole project. It's quite difficult as you don't want to hinder any future interoperability. And we, as a producer, are trying to imagine what the consumers' systems will need and how they want to integrate, and also what other systems with similar use cases might be doing, etc., etc. Another area has been the internal understanding of how the FHIR and RESTful standards work. You might think that it's more a question for architects and developers, but also requirements analysts, product owners, customer managers, etc. need to understand the possibilities and boundaries of these standards. You are no longer free to decide in detail how the API should work in each situation. And the good thing about that is it makes it much easier for us to keep track of how the same data is accessed and used in different scenarios where you might have different product owners, different solution architects, etc. But for all this to work smoothly, your organization needs to have a basic understanding of how you should use the standard. Moving over to profiling, that's a difficult area, and I would like to talk about two different aspects of profiling that we have been struggling with. So the first one is try not be special paradigm, which in practice means that you should follow existing patterns and best practices. But how do you do that? You need to read the FHIR spec forwards and backwards many times, engage in Zulip chats, look at other organizations, projects, etc., etc. It takes a lot of time, and in the end, you're not still sure that you've got it right. But as we are working in a national project, we would really want to get it as right as possible. A completely different aspect is the usability of your API. When handling health-related data, medications in our case, you really want the connecting systems to get everything right. A key component is that your APIs are clear and easy to understand. You want it to be obvious to the external system developers how the APIs work, what you can do and what you cannot do. If I should pick one especially difficult area, I would choose the dosage backbone element that is used in both medication request and medication dispense. This dosage structure, it allows for a vast number of combinations. And we had to find a reasonable level where we allow the connecting systems to make the kind of structured dosages that they need for their patients, but at the same time keeping the complexity at a reasonable level for all systems that will be required to interpret the dosage data and display it for the users. Another very important part of your FHIR API is your documentation, and I'd like to mention a couple of our challenges in this area. So first, of course, the language. The FHIR standard is in English, and we are using it for a national Swedish project. Therefore, some parts of the documentation need to be in English and some parts in Swedish. But where should we draw the line? We know that some of our connecting systems have their development teams in other countries than Sweden and don't speak Swedish. On the other hand, the Swedish organizations using the systems also need to understand our documentations, which in many parts it's closely linked to the Swedish laws with very specific Swedish terminology, of course. So also, how do you get the documentation to work as a whole? We're currently using Simplifier for our documentation of our profiles and how you should interact with them. But we, at the same time, have implementation specifications that describe how the data should be used in different scenarios. Also, as I mentioned, we have those existing APIs that also need to be integrating in the different functionalities that the systems will have to implement for the users. And how do you get that to flow nicely with the new documentation about the FHIR APIs? Finally, some words about our next steps. As I mentioned, we are now in a situation where we have two separate technologies for our APIs. So the goal is to continue moving towards FHIR. So we want to apply FHIR to the rest of our existing APIs. Then there are some areas that we want to develop further. and I thought I'd mention a few of them. One area is validation. So far, we haven't used so much of the possibilities that FHIR has to offer in this area. So this is something that we will have to look into in more detail. Another area is the provenance resource. We are using the provenance resource today for logging change history, but we know that there is a need for functionality in the connecting systems to easily find clinically relevant changes in a patient's medication list. So we are hoping that we can use the provenance resource for this need as a useful tool. Versioning is also an area that we'll have to continue to work with. We know that the future requirement will be that we must have 2 separate releases of our FHIR server running in parallel, and we have a theory about how this will be done. But still, there are many details we have to decide regarding, for example, how we should handle new FHIR versions, containing new versions of the resources that we are using, how and when we then should update our profile versions, etc., etc. There will also certainly be lots of areas that we will have to continue to develop as we get more and more feedback from the systems that are now connecting to the National Medication List. And of course, we also hope that we can contribute to the development of the FHIR standard with our findings in this project. Here are some contact details if you contribute to the development of the FHIR standard with our findings in this project. Here are some contact details if you want to reach out with more questions or some other feedback. And finally, moving over to the Q&A session. So are there any questions?
Thank you very much for your video, Emmeli. Sorry for the little skip back. I noticed that the video paused for a second, so I thought I would just put it back a bit so that at least the last part comes through clearly as well. So excuses for that, but now the video is completely finished at least. You can turn on your mic now. Yes. So I have one question for you. In the end of the video, you left the little dots when it comes to future FHIR mechanisms that need further adoption. Are there any others that you left out because of time constraints, or was that the dots that? Yeah, you get my question.
Yeah. No, not any specific that I was thinking of mentioning, just leaving it sort of as an open area that there are always possibilities to improve your APIs. And then there is this fine line where you need to find a reasonable API. It shouldn't be too complicated and you shouldn't use too many mechanisms, perhaps, to make it, jumping around the screen.
Oh, yeah.
So, yeah.
Then I have one other question. What should others keep in mind? You named a few FHIR challenges you had yourself. What should others take away from that so that they skip that part and do not make the same mistakes? Or if you can call them mistakes.
Yeah, well, probably with looking backwards, or our future selves will look back and see a lot of mistakes we don't realize today that there are mistakes. But what should I say as a good tip? It takes a lot of time. That's something for sure. So
don't try to rush through everything.
Yeah, or you need to prepare that it takes a lot of time, and there are many details that you think first that this is easy, but then you start digging into it, you realize it's difficult. And I saw someone had posted in a discussion available in Hoover about how do you learn FHIR, and somebody talked about this coding, codable concept. It looks easier, but when you start digging into it, it's quite difficult to grasp and the difference between something that looks very similar but means something very different when you use it in different scenarios. So that's one important thing. Don't be stressed, because then you will certainly get it wrong. But also, as I mentioned there, that your organization needs to understand a lot about FHIR, because if you're going to adopt it, you can't just put an API on top of everything and hope that it works smoothly. You have to have some kind of internal understanding and acceptance of FHIR and the boundaries. We have had a lot of questions with requirement analysts as why can't we do this and why can't we do that, because the FHIR standard says so. And we pick the standard and then we should follow it, not do it our way. So the try not to be special paradigm is very, very important, I would say.
All right, great. Good elaboration. I have one more question in my mind. It just popped out. Actually, what surprised me was how quite far, if you ask me, the Swedish National Medication List is. If it's already going to be implemented next year, and even well, and if it's going to be mandatory by 2023.
Yeah.
Even though at the same time you're saying we should not rush through everything, is that something that actually made it, in the end, made it way easier?
Yeah, we've been working with the project for 2 years now, and we have always, or for a long time, we've thought that very soon finished, we will soon be finished, but it takes really a lot more time than you think, because as I said, every detail you start digging into, it's quite complicated. And especially we think that we are doing a national project, and we hope that we are doing things quite right, so other scenario or other projects can copy solutions that we have made, and then we want them to be, well, quite good.
All right.
Not workarounds. So.
And that aligns with another question somebody who David Simmons asked. Are you planning or aligning with other EU member states on the medication list harmonization?
You have an initiative with this what's it called, cross-border e-prescription services, but they are not currently working with FHIR. I think that's a new initiative. But we are ourselves looking into using FHIR in some of the implementation. But well, I don't know what will happen with that. I'll have to get back to you with more information about that. I don't know the current status.
All right, that's also an answer. Can't know everything. Then there's one more question. Is the current SOA-based solution also implemented at the national level? And for how long do you anticipate to have two parallel paradigms? Sorry.
Yeah, I wish I could answer that. As we are an agency, it depends on how much money we are getting from the government. So, and that you never know. Hopefully, it won't be that many years, but who knows? As you know, all this with the COVID-19 and Corona is affecting everything, and we also have to save money. So depends on how much money we're getting for our development projects. And also everything we do, of course, with our APIs are affecting the connecting systems. So it's not like they're doing hooray or changing everything. And so the systems that are already connected, they're not so happy when we're making changes, but new systems are much happier, because then they get the better, newer technologies and better quality in the APIs. Some things we have learned along the way. So,
all right.
But I would maybe not put any money on being in. It will take a couple of years, maybe 5 years. I will put my money on that.
All right, it seems like a good bet. But we already ran out of time, sadly. Thank you very much for your time. It was a good presentation. And enjoy the rest of DevDays.